I'm Dr. Fakir Abadi, and this is Clostridioides difficile infection in adults. Clostridioides difficile, or C. diff, was formerly known as Clostridium difficile when nomenclature changed in 2018. C. diff is a gram-positive anaerobe, and it has two important characteristics. The first one is that it's spore-forming. It can survive in aerobic conditions by forming spores, and alcohol rubs are ineffective against spores, which makes washing hands with soap and water extremely important. Spores are stable in acidic environment as well, such as the stomach. The second aspect of C. diff is that some strains are toxigenic, meaning that they can produce toxins. Specifically, C. diff, toxigenic C. diff, can produce toxin A and toxin B. And I'll explain what the consequences of these toxins are. C. diff infection is extremely important because it is attributed to extreme healthcare costs, as well as 5% infection-related mortality and 15 to 20% all-cause mortality. In fact, the CDC has classified C. diff as an urgent level of threat because of its prevalence and associated death. Although the rate of C. diff has been going down in recent years thanks to antimicrobial stewardship efforts, the annual cases requiring hospitalization are still in excess of 200,000. Now, to demonstrate how prevalent C. diff is, you can see the rate of C. diff on the left-hand side compared to the rate of ESBL infections, which is much more common than multi-drug resistant Pseudomonas, which is more common than carbapenem resistant Enterobacterales, which is more common than carbapenem resistant Acinetobacter. So you can see that C. diff infection is a serious infection that's very prevalent. And to make things worse, it is also associated with increased rate of death. And you can see that the rate of mortality from C. diff is significantly higher than mortality due to ESBL infections, which is significantly higher than multi-drug resistant Pseudomonas, which is higher than CRE and CR Acinetobacter. Let's take a look at the pathophysiology of C. diff infection. It requires both acquisition of C. diff as well as disruption of the gut microbiota, because the gut microbiota has a protective role against C. diff. Although the exact mechanism of symptomatic infection is unclear, toxins play an important role. The toxins produced by C. diff can disrupt the epithelial cells inside the GI tract, which can result in release of inflammatory mediators, and this immune response can be severe in many patients. In fact, the clinical manifestations range from diarrhea to pseudomembranous colitis to toxic megacolon, colon perforation, and death. As I mentioned, the healthy gut microbiota have protective role against C. diff. When patients are exposed to antibiotics, the normal gut microbiota is disrupted. This leads to decreased species abundance as well as decreased diversity in the gut microbiota. In patients with disrupted gut microbiota, the C. diff spores find the opportunity to germinate to vegetative cells, and then they can grow and dominate the GI tract. And then once C. diff colonizes in the colon, some patients may remain asymptomatic. That depends on whether their immune system will respond to toxins produced by C. diff. For some patients, these toxins will induce an immune response, and depending on the severity of the immune response, there can be serious consequences, such as hypotension or shock, ileus, or toxic megacolon. These patients are the most difficult to treat and have the highest risk of mortality or need for surgical intervention to manage CDI. When patients receive treatment with antibiotics for C. diff infection, the clinical symptoms will be resolved. Over time, the healthy gut microbiota will be restored, protecting the patient against future C. diff recurrences. However, if the gut microbiota continues to be disrupted, then the patient will be at risk of getting recurrent C. diff infection. Alright, let's take a look at how someone acquires C. diff infection. So, initially someone is C. diff negative, and when this person gets exposed to the healthcare setting, they are immediately at risk of acquiring Clostridioides difficile. And one thing that can happen is that this person can actually acquire non-toxigenic variant of C. difficile. And of course, because this non-toxigenic, this patient will not have symptoms. So this will be an asymptomatic colonizer. Another thing that can happen is that someone can be exposed to toxigenic variant of C. diff, and their immune system can actually mount immunoglobulin G response to the toxin A. And because this immunoglobulin will actually neutralize the toxin, this patient also will not have symptoms. So this patient will be asymptomatic colonizer. A third option is that when someone is exposed to toxigenic C. diff, their immune system cannot mount immunoglobulin G response to the toxin. And because the immune system cannot neutralize the toxins will develop symptoms. So this will be symptomatic C. diff infection. Now, all three of these can transmit C. diff to other people, especially if they are asymptomatic and they get discharged home prior to being treated. Now, with the initial case of asymptomatic colonization with a non-toxigenic, this is not a problem because this is pretty benign, this strain of C. diff. The problem is with the toxigenic C. diff. So someone who's asymptomatic can go home and transmit this to other people like family members or friends, which can lead to community transmission of C. diff. And this symptomatic C. diff, of course, will be treated and will be in isolation to have infection control. Although healthcare and chronic care facilities have been typical places in which patients acquire C. diff infection in the past decade, more patients are presenting with community-acquired C. diff infection. Now, let's take a look at reliable resources. So in general, we have IDSA and ACGs, American College of Gastroenterology, have recommendations for C. diff infection. In 2017, IDSA actually released a guideline for infectious diarrhea. This is for management of infectious diarrhea due to other causes other than C. diff. So C. diff is not included in this guideline. But in 2017, they also released a guideline specifically for C. diff infection. So any diarrhea due to C. diff. This was in collaboration with Shea. Recently in 2021, ACG, American College of Gastroenterology, also released updated guidelines for C. diff infection. And these guidelines are actually in agreement with the 2017 IDSA guidelines. And then shortly after ACG guideline was released in 2021, IDSA also released a focused update, which basically updated 3 recommendations. So this is a supplement to the 2017 IDSA guidelines. So there are a lot of recommendations in 2017 guidelines, and this focus updates basically as 3 recommendations or updates a couple of old recommendations. And lastly, there is a 2020 guideline from American Gastroenterology Association, specifically for the role of probiotics in the management of GI disorders. The first learning objective is describe the PK/PD properties of antibiotics used for CDI. Metronidazole essentially disrupts the DNA and inhibits nucleic acid synthesis. It is available both as IV and PO. Note that with the PO, it is 80% bioavailable. Now for CDI, the site of infection is actually in the GI tract. So it's actually best if the drugs are not absorbed, because when they are absorbed, they go away from the site of infection. So when 80% of oral metronidazole is absorbed, about 20% of it stays in the site of infection. And of course, with IV, 100% bioavailability means that the entire drug goes into the bloodstream, and then a portion of it may actually go from the blood to the GI tract. One adverse effect that's unique to metronidazole is that the patients might get metallic taste. Now, this is specifically with the oral formulation, not with the IV. For vancomycin, we have two oral vancomycin formulations. So we have vancomycin, which is basically a capsule, and we have more recently Fervanc, which is an oral solution. Now, because these oral formulation of vancomycin are very expensive, we actually in the hospital, we can use the IV formulation of vancomycin as oral because the IV formulation, which is meant for injection, is quite inexpensive, can actually give it orally. But regardless, for treatment of C. diff infection, vancomycin must be administered orally. So IV vancomycin as an injectable is not an option. And this is really important because pretty much less than 1% of vancomycin is absorbed. So it actually stays at the site of infection. So this is excellent. Now we also have fidaxomicin, which is available as an oral tablet. This also does not get absorbed, so it stays at the site of infection. We also have rifaximin, which is also not absorbed. And more recently, we've had bezlotaxumab, which is a human monoclonal antibody, which basically binds to the toxin B, and it prevents the toxin from having its effects on the cells. And this is specifically IV, and I'll explain more about this. Now, one thing that's important about bezlotaxumab is that heart failure was actually reported more commonly in the patients that received this agent in patients with a history of congestive heart failure. So in patients with a history of CHF, bezlotaxumab should be reserved for use when the benefit outweighs the risk. And this is from the package insert. Now, I want to draw your attention to the fecal concentration of these drugs because the site of infection is in the GI tract. You will see that because oral metronidazole is mostly absorbed, you get the significantly lower concentration in the feces, and this is in microgram per gram of the feces. Whereas with vancomycin and fidaxomicin, you get significantly higher concentration. So I want you to keep that in mind when we talk about the efficacy of these agents. We described the PK/PD properties of antibiotics used for C. diff infections. Now, let's identify risk factors for the development of new onset and recurrent C. diff infection. The IDSA guidelines require two things for the C. diff infection case: the presence of diarrhea or evidence of megacolon or severe ileus, and either a positive laboratory diagnostic test result or evidence of pseudomembranes demonstrated by endoscopy or histopathology. Recurrent C. diff infection is defined as repeated episodes within 2 to 8 weeks of the previous episode of C. diff infection. So repeat infection after 8 weeks is actually considered new episode C. diff infection. Let's take a look at the effect of antibiotics on the normal gut flora. In healthy patients with no risk factors for C. diff infection, the gut flora includes both a high quantity of bacteria as well as a high diversity, represented by the red graph. Now, if someone takes antibiotics in this blue, represented in the blue zone here, the quantity and diversity of normal flora will drop, which will place the patient at the risk of getting C. diff infection. And of course, the C. diff strains that are resistant to whatever antibiotic that was used actually have selective advantage in this disrupted flora. Of course, these are antibiotics used for other infections such as pneumonia. Now, once the treatment of antibiotic for whatever infection is done, then there is a period of no antibiotic. This allows for the normal flora to return to the normal state. Now, as the normal flora is restored, then the risk of C. diff goes back down to the level that there will be no risk for C. diff infection. Now, when antibiotics are discontinued in patients, the time that it takes for flora to return to normal state is very variable and it takes a long time. Therefore, there is a gap between this because of variability in patients. It often takes several months for the flora to return to normal state. Let's look at risk factors for new onset C. diff infection. Antibiotic usage, as I explained, is a huge risk factor for C. diff infection, so is age greater than 65 years. About 94% of all C. diff infection cases have a recent healthcare exposure, so recent hospitalization is a risk factor, as well as VRE colonization. So patients who receive antibiotic are more likely to have vancomycin-resistant enterococcus colonize the GI tract. So this makes sense that people who have VRE, in fact, about half of the patients with C. diff infection often have VRE colonization. Other risk factors include the receipt of chemotherapy, immune compromise or neutropenia, feeding tube, residence in nursing home, chronic kidney disease, and something that's a bit controversial is the receipt of proton pump inhibitors. In observational studies, proton pump inhibitors have been associated with C. diff infection. In fact, more so than histamine 2 receptor antagonists. And this association is typically in chronic use of PPI. So typically, patients who are on a PPI for more than 28 days are at increased risk of C. diff infection. And this may be more of a marker. So someone who's receiving PPI chronically might have other comorbidities that are more likely to expose them to C. diff infection rather than the acid suppression itself leading to C. diff infection. Because as we know, Clostridioides difficile can present as spores, and spores are actually stable to the acidic environment. So whether the acids are inhibited or not is not really going to have a direct impact on C. diff infection, but this is an association to increased risk of C. diff infection. Things that manipulate the GI tract, such as feeding tube, gastrointestinal surgery, are considered risk factor for C. diff infection because they can disturb the flora. Now let's talk about the elephant in the room, antibiotic usage. The highest risk of C. diff infection is during receipt of antibiotics and in the first month after finishing the antibiotic. And we're talking about antibiotics for other indications such as urinary tract infections or bacteremia. Now, this risk can continue to exist up to 3 months after cessation of antibiotics, and it is dose dependent. That's associated with increasing cumulative antibiotic dose. So the higher the dose, the higher the risk, as well as increasing number of antibiotics. So combination therapy, higher risk than a monotherapy with antibiotics. And of course, increasing number of days of antibiotic exposure. So every single day of antibiotics will increase the risk of C. diff infection. So the sooner we can discontinue antibiotics, the better it is in protecting the patients from getting C. diff infection. Now, certain antibiotics have higher risk of antibiotics. In general, pretty much every antibiotic has been associated with C. diff infection because one way or another they have the propensity to disturb flora, but some antibiotics significantly more than others. So you can see that on the top of the list, we have clindamycin, which has been historically associated with one of the highest rates of C. diff infection, along with cephalosporins, fluoroquinolones, carbapenems, penicillins, and this includes penicillins combined with beta-lactamase inhibitors such as piperacillin tazobactam, as well as combination therapy. So if you combine multiple antibiotics, for example, when you do empiric treatment. Now, at the same time, there are certain antibiotics that have low risk of antibiotics. And at the top of the list is tetracycline. Specifically, doxycycline has been shown to have very low risk of antibiotics. And some studies have even suggested that doxycycline might protect from getting C. diff infection. Other antibiotics with low risk include glycopeptides, oxazolidine Dinones such as linezolid, metronidazole, nitrofurantoin, and trimethoprim sulfamethoxazole or Bactrim. Let's talk about risk factors for recurrent C. diff infection. About a quarter of patients will actually have recurrent C. diff infection after the first episode. You will immediately see that risk factors for recurrence basically are the same risk factors as getting the first episode of C. diff infection, such as advanced age and receipt of antibiotics. And the patient's immune system plays a role here. So when we give antibiotics to a patient which will disrupt the normal flora, the patient will be at risk of getting toxigenic Clostridioides difficile, and then inside the patient, the bacteria will start the toxin production. And then once the toxin is produced, then the immune system can actually respond. So if the patient has sufficient immune response, meaning that the body will actually have antibodies against the toxin, so antitoxin response, this patient will actually be asymptomatic carrier. Now, if the patient has inadequate immune response, these patients will have symptoms, including complications such as colitis. And then, if this inadequate immune response continues, that's when these patients will have recurrence of C. diff infection. Now, it is possible for someone who had delayed immune response, they might have a first episode of C. diff infection, and then in time they can have immune response and their body will have antitoxin antibodies, and then they will have resolution. So that explains why even with these patients who have recurrence after the first episode, pretty much 60% will have cure. These are the patients that had delayed immune response. And then there are about 40% of patients that just don't have immune response, so they will continue to have recurrence C. diff infection. So it's important to note that recurrence is not thought to reflect an antimicrobial failure, but rather is a failure of the host to either reconstitute his or her microbiota to establish colonization prevention, or failure of the host to develop a protective antitoxin antibody immune response during the initial infection, or both. It also makes sense that advanced age is a risk factor because advanced age is associated with low antitoxin B antibody. In fact, antitoxin B titers at baseline and at week 4 correlate inversely with recurrent C. diff infection in studies. We looked at PK/PD properties of antibiotics used for C. diff infection and identified risk factors for the development of new onset and recurrent C. diff infection. Now, let's assess clinical presentation and diagnostic laboratory findings to determine if a patient has CDI. Clinical presentation of CDI can range from asymptomatic in those who have immune response to the toxins producing antitoxin antibodies to patients who do not have immune response and develop diarrhea, and for some patients fever, abdominal pain, nausea and vomiting. And complications of CDI can include pseudomembranous colitis, toxic megacolon, shock, and of course death in severe cases. Diarrhea is the point where clinicians have to decide if it's due to CDI or due to other causes. Diarrhea can range in severity from minimal self-limited disease to profuse with 2 or more episodes per day. Now, about a quarter of patients can actually be expected to resolve the symptoms by simply stopping the offending antibiotics without using any specific C. diff infection treatment. Now, one significant finding in patients with C. diff infection includes leukocytosis. It is very common to have patients with C. diff infection present with white blood cells more than 25,000 cells per ml. And in fact, for some patients, in severe cases, white blood cell can exceed 100,000. In this picture, we can see what the toxin A and B can do to the colon, resulting in these lesions throughout basically the colon. And this is where the patients will have complications by forming pseudomembranous colitis. This is where the epithelial integrity will be disrupted throughout the colon, leading to these lesions. Now let's take a look at diagnosis of C. diff infections. The IDSA guideline recommends that patients with unexplained and new onset with at least 3 unformed stools in 24 hours are preferred target population for testing for C. diff infection. In other words, if someone only had 1 or 2 watery stools, they're not really a candidate for testing for C. diff infection. And by 2, I mean within 24 hours. It's important to avoid routinely testing stool from patients who have received a laxative within the previous 48 hours because laxative can lead to these frequent unformed stools, and that would be a more likely cause of watery stool as opposed to C. diff infection. Now, in general, the 3 commonly used tests include nucleic acid amplification test, or NAT. So this is basically a PCR-based assay. We also have stool toxin enzyme immunoassay test. We also have glutamate dehydrogenase, or GDH test, which is considered a C. diff antigen. Now let's take a look at the differences between these. The nucleic acid amplification test is by far the most sensitive and specific test. The cost is significantly high, but is starting to go down compared to other tests that are available on the markets right now. Now, pretty much all of these tests are pretty rapid, so the results will be available quickly in the same day. The GDH test basically detects the highly conserved metabolic enzyme, which we call the common antigen, which is present in both toxigenic and non-toxigenic strains. So it basically tells you if the C. diff is there, it just doesn't tell you if it's toxigenic or non-toxigenic. Now it's important to know that this test is sensitive, but it's not specific. With the stool toxin enzyme immunoassay, this is the test that actually tells you if the toxin is present or not. So the GDH test and this toxin immunoassay, enzyme immunoassay, are actually used in combination. So together they will tell you if the C. diff organism is there, and then it will tell you if it's toxicogenic or not. Now, with the nucleic acid amplification test, because it's very sensitive, it's important to only test the sample from patients who actually have signs and symptoms of C. diff infection. Because if you were to do this on any stool sample, then you're going to identify all the colonizers. So it's very important to avoid over diagnosis of C. diff infection. So clinicians can improve laboratory test relevance by only testing patients likely to have C. diff disease. This includes not routinely performing tests on stool from a patient who has received a laxative within the previous 48 hours. Now, laboratories can also improve specificity by rejecting specimens that are not liquid or soft. Now, the IDSA guideline basically has 2 ways for diagnosis of C. diff infection. So for institutions that actually require clinical signs to be satisfied prior to submission of stool sample for testing, for those institutions, you can either do the nucleic acid amplification test alone, or you can use a multi-step algorithm. Now, in institutions that there is no agreement between the lab and clinicians to only test the sample from those with clinical signs, then a nucleic acid amplification test alone is not recommended. A multi-step algorithm is recommended. And here's what the multi-step algorithm looks like. So basically, once the stool sample comes into the lab, we will perform enzyme immunoassay for the GDH. So that will tell you if the C. diff organism is there or not. And then they will perform a enzyme immunoassay for the toxin A and B, and this will basically tell you if the strain is toxigenic or non-toxigenic. So if both of these happen to be positive, so if it's GDH positive and toxin positive, then the conclusion is that the patient has C. diff infection. And of course, on the other hand, if both of them test negative, then it's concluded that the patient does not have C. diff infection. Now, if there is discrepancy between these two, meaning that either GDH is positive and toxin is negative, or GDH is negative but toxin is positive, then it's recommended in this algorithm to do the nucleic acid amplification test just to confirm this discrepancy. So if you do the PCR, which basically pretty much the PCRs that are available, they look for the gene for the toxin B, and if the gene is there, then the conclusion is that the patient has C. diff infection, whereas if the gene is not there, then the conclusion is that the patient does not have C. diff infection. Now, according to IDSA, do not repeat testing within 7 days during the same episode of diarrhea, and do not test stool from asymptomatic patients except for epidemiologic studies. However, for symptomatic patients with a high clinical suspicion of C. diff infection but a negative C. diff infection test, particularly those in whom symptoms worsen, a repeat testing should be considered. Now, given that recurrent C. diff infection occurs commonly, a recurrence of symptoms following successful treatment and diarrhea cessation should be assessed by repeat testing. Now, once somebody receives treatment for C. diff infection, there is no clinical value in repeat C. diff infection testing to establish cure, because more than 60% of patients may remain C. diff positive even after successful treatment. We described the PK/PD properties of antibiotics used for C. diff infection and identified risk factors for the development of new onset and recurrent C. diff infection. We also assessed clinical presentation and diagnostic laboratory findings to determine if a patient has C. diff infection. Now, given a patient with new onset or recurrent C. diff infection, recommend IDSA guideline-concordant treatment. Here are the IDSA recommendations for treatment of initial C. diff infection. We will separately look at recurrent C. diff infection, but now let's take a look at the very first episode of C. diff infection. We should break this into non-severe, severe, and fulminant episodes of C. diff infection, and the definition of non-severe includes a white blood cell count of less than 15,000 and serum creatinine less than 1.5. And for these non-severe patients with C. diff infection, the new 2021 IDSA guideline actually recommends fidaxomicin as preferred regimen over vancomycin. This recommendation is made because it has been proven that fidaxomicin has lower rate of recurrence of C. diff infection, and although fidaxomicin, a full treatment course, costs about almost $5,000, cost effectiveness analysis probably favors the use of fidaxomicin over vancomycin in patients with an initial episode of C. diff infection due to its greater effectiveness with respect to sustained clinical response, but implementing this recommendation probably reduces equity due to variation in medical insurance coverage. Now, in settings where access to vancomycin or fidaxomicin is limited, IDSA suggests using metronidazole for an initial episode of non-severe C. diff infection only. And this is because of inferior efficacy of metronidazole for this infection. Now, it is important to avoid repeated or prolonged courses of metronidazole due to risk of cumulative and potentially irreversible neurotoxicity. Now, because of cost of fidaxomicin, it is likely that for the foreseeable future, vancomycin will continue to be used for most patients. However, as cost starts to go down and as people start to adapt this new recommendation, we will see increased use of fidaxomicin for patients, which will ultimately reduce the risk of recurrent C. diff infection. Severe C. diff infection is defined as white blood cell greater than or equal to 15,000 or a serum creatinine greater than 1.5. For these patients, metronidazole is not an option because of inferior efficacy and high risk of complications and mortality in these patients. So again, fidaxomicin is the preferred regimen according to the 2021 guideline, and vancomycin is also an option as an alternative to fidaxomicin. And we also have fulminant C. diff defined as either hypotension or shock, or ileus, or megacolon. And ileus is basically if there's obstruction in the colon. And for these patients, it is recommended to use a higher dose of vancomycin at 500 milligram, either PO, or if the patient is unable to take oral medications because they're either in hypotension, shock, or because of clinical instability, it can be administered through a nasogastric tube. And in addition, it should also be coupled with IV metronidazole. And this is because if there is an obstruction in the GI tract and this oral vancomycin cannot get to the site, which is basically into colon, this IV metronidazole will basically surpass that obstruction in the GI tract and will be able to infuse from the blood into the GI tract and get to the site of infection. And this combination has actually been shown in observational studies to reduce mortality, and that's why it's recommended here. And for ileus specifically, since oral vancomycin will not get to the site of infection, you may consider adding rectal instillation of vancomycin, basically at the same dose of 500 milligram 4 times a day. And it is important to note that for fulminant C. diff infection, fidaxomicin is not recommended because it has not been studied for these patients. So all the studies of fidaxomicin excluded patients with fulminant C. diff infection. Now you will see that one thing that's clear here for non-severe and severe C. diff infection is that fidaxomicin has a clear advantage of twice daily dosing, so it's BID, whereas vancomycin is dosed 4 times a day, so it will actually improve adherence. Now, one thing to note is that while these are treatment of C. diff infection, it is important to target the underlying cause. So it is important to discontinue therapy with the citing antibiotic agents as soon as possible, as this may influence the risk of C. diff infection recurrence. So, if a patient is on fluoroquinolones, for example, it is important to, if possible, to discontinue as soon as possible. Now, one thing that may be controversial is the use of anti-motility agents, since these patients have diarrhea. And because, C. diff is toxigenic, and, some people argue that because we want the toxins to get out of the colon, it might be a good idea to not use anti-motility. IDSA guidelines actually say that addition of anti-motility agents such as loperamide as an adjunct to specific antibacterial therapy for C. diff infection may be safe, but they do acknowledge that there are no randomized controlled trials conducted to evaluate the safety of that. Okay, now let's take a look at recurrent C. diff infection. So for the very first recurrence, so this is someone who already had C. diff infection one time and got treated, and then had recurrence 2 to 8 weeks after treatment. Again, fidaxomicin is the preferred regimen, and for these patients also another preferred regimen is an extended pulsed dosing version of fidaxomicin. You basically give the same total number of doses. So if the normal dose is 200 milligram twice a day for 10 days, that's a 20 dose regimen. One study looked at giving the 200 milligram PO/BID for 5 days, and then every other day dosing for 20 days, which you end up with the total number of dose overall. And this actually reduced the number of recurrence to the maximum. And of course, if cost is an issue, alternative regimens include prolonged taper and pulsed vancomycin. And what that means is that you basically give 125 milligram of vancomycin 4 times a day for 10 to 14 days. And then you basically taper it down to twice a day for 1 week. And then you taper it down to once a day for 1 week. And then you taper it down even further to every 2 to 3 days for 2 to 8 weeks. So this is why it's prolonged. And this has been shown to be effective for recurrent C. diff infection, although it has not been compared head to head with fidaxomicin, so it's not clear if this would be more effective than fidaxomicin. So for that reason, it is alternative. And lastly, of course, especially if someone who initially received metronidazole and then they had recurrence, vancomycin, the usual dose of 125 milligram 4 times a day for 10 days is an alternative. And metronidazole is not recommended for any recurrent C. diff infection. Now let's take a look at recommendations for second or subsequent recurrences. And basically fidaxomicin again is the preferred recommendation, as well as the extended pulsed fidaxomicin dosing. An alternative recommendation is prolonged taper and pulse vancomycin, and of course the regular vancomycin dose followed with a chaser. So the chaser is that you do the regular 10 days of vancomycin and then you do rifaximin 400 milligrams 3 times a day for 20 days. And then at this point, because you are at the second and third and fourth and fifth recurrences, and this becomes really burdensome, some of the effective treatments that are reserved for this phase includes fecal microbiota transplantation. So this is recommended for after 3 C. diff infections episodes. There is also adjunctive bezlotaxumab, 10 milligram per kilo, just one time. And this basically, because of the long half-life of 18 to 19 days, it will basically stay in the body for about 3 months. So it's very effective in reducing recurrence of C. diff. And that, it's important to note that bezlotaxumab is really to reduce recurrence. It is not for the treatment of C. diff infection. So that's why it's adjunctive. So, for example, if you give it with vancomycin, the vancomycin will be for treatment, and bezlotaxumab would be to reduce the risk of recurrences. And it's important also to note that bezlotaxumab data is in combination with vancomycin or metronidazole. There are limited data with giving bezlotaxumab along, combined with fidaxomicin. Now, in settings where logistics is not an issue, patients with a primary C. diff infection episode and other risk factors for C. diff infection recurrence may particularly benefit from receiving bezlotaxumab because of its effectiveness in reducing recurrence, especially those, people with risk factors such as recurrent C. diff infection episode within the last 6 months, or age 65 years or older, immunocompromised patients, and severe C. diff infection on presentations. Now, one thing that's important to note is that in patients with a history of congestive heart failure, bezlotaxumab should be reserved for use when the benefit outweighs the risk. Lastly, there are some recommendations for prevention of C. diff infection. The IDSA guidelines say that there are insufficient data to recommend screening for asymptomatic carriage and placing asymptomatic carriers on contact precautions. They also say that it's important to minimize the frequency and duration of high-risk antibiotic therapy and the number of antibiotic agents prescribed to reduce C. diff risk, and also to restrict fluoroquinolones, clindamycin, and cephalosporins, because these are very high risk for C. diff infection, except for surgical antibiotic prophylaxis. So those should not be restricted. So, and often you will see that antimicrobial stewardship programs do restrict the use of fluoroquinolones. For example, it is a bit more difficult to restrict cephalosporins and clindamycin because of their clinical utility. And the 2017 IDSA guidelines regarding probiotics, they mentioned that there are insufficient data to recommend probiotics for primary prevention of C. diff infection. So they need to see more clinical trials. And the more recent 2021 American College of Gastroenterology guidelines recommend against probiotics for prevention of C. diff infections in patients who are treated with antibiotics. They also recommend against probiotics for prevention of C. diff infection recurrence. This concludes this presentation.